Now, I call upon Dr. Mathew Kurian to talk to about converting to SICS in a do-or-die situation, golden tips. Dr. Mathew is a very senior and prolific cataract surgeon, ex-medical superintendent of Narayan Nethralaya and now of Chaitanya Eye Hospital. And I was really impressed with one of the videos he showed in AOS about conversion from a tunnel without making a scleral groove and doing the escape. Over to Dr. Mathew.
Thank you. So, often when we are doing surgery, especially if you are doing it under topical anesthesia, when you have a complication, you have to have a plan to get out of trouble. And we can, of course, make a superior incision separately, but what I prefer to do is make my primary incision as a sclerolimbal incision, so that then I can make back cuts and scleral pocket, get a good internal corneal lip, and then have a square wound at the end of it. This cannot be done for the first time when you have a intraoperative complication. You need to practice it. So SICS cases, I typically do sclerolimbal incision or a posterior limbal incision, and then instead of putting doing a rigid lens, I have this to practice, so that intraoperatively during cases I am able to convert into a practiced plan B escape route. Pseudo exfoliation, mature, hypermature cataract, and you can see this very leathery hard thing. There is flicker. I feel there is zonular dialysis or zonulopathy. The rhexis is adequate for phacoemulsification. It is not adequate for conversion to SICS. So I am making a small nick, and then using microrhexis forceps, I have then converted it into a larger rhexis, which is adequate to prolapse this very hard nucleus out of the bag. So through the side port, now that I have the things in the anterior chamber a little bit stabilized, I am using a Sinski hook to gently prolapse. Remember, this is 360-degree laxity with probable zonular dialysis is what I am thinking of. And so very gently I extend it, prolapse the nucleus into the anterior chamber. Things are controlled in the anterior chamber. At this point, then I go into the wound using the same crescent itself. It has to be a new crescent. I do a transconjunctival back cut. The conjunctiva cuts at one point. The sclera is actually at getting incised at a different point. I make the scleral pouches backwards and then extend into clear cornea. Good internal corneal lip is necessary, and then I make the wound internal opening, which is at least almost from 10 o'clock to 2 o'clock or even larger. Once this is achieved well, I can just use visco expression and deliver this nucleus. So it's a very large nucleus, as you can see, and that is it is possible to deliver that using visco expression. I am then now using the planned lens in this situation was single piece hydrophobic acrylic lens, dial it into the bag under viscoelastic, and because I know that there is 360-degree laxity because of the pseudo exfoliation, I put in a CTR to support this, and at a later date, if there is a bag IOL CTR complex dislocation, this the fibrosed bag, through the CTR you can actually hook it and suture it and stabilize the bag at a later date if needed. So that's the end of that. The last portion, I prefer not to use a Sinski hook. I use micro forceps to deliver and place it correctly. This wound can be left unsutured, or if you feel that it is not perfect internal corneal lip is not there, then you can put a suture. This is a trainee that was operating divide and conquer. Initial steps going well. First crack achieved, second crack achieved, and then change from trenching to the quadrant removal, and at this time goes too deep to the periphery, and you can see the posterior capsule has opened. How would you proceed? We want first a sutureless astigmatically neutral wound. Our second desire is to have complete nucleus and cortex removal and a AC which is free of vitreous, and complete separation between the posterior and anterior segments. So again, at this point I have taken over, starting from within the existing wound, back cuts at 45 degrees to extend the cord length will be approximately 7 millimeters on the exterior and 8 or 9 millimeters on the interior. Since fragments are already created, it's actually a little more difficult to prolapse and get these pieces out. Gently bring a fragment at a time into the anterior chamber and deliver it using some heavy molecular viscoelastic to tamponade the area of the rent. Then judicious use of cut IA and IA cut is used to clear the anterior chamber of vitreous, and then go into IA cut to clear the cortex, and a multi-piece lens which is desirable in all situations to have a standby is used, placed in the sulcus with an optic capture to achieve the complete separation between the anterior segment and the posterior segment. So the optic capture ensures that there is complete separation. The haptics in the sulcus ensure that this lens will not displace. Thank you very much.
Thank you, Dr. Mathew. It's a wonderful demonstration of a very useful technique. I think, like you mentioned, it shouldn't be the first one when you're confronting a problem. You should be experienced in a normal case doing it like you said. That will be the take home. And thank you so much. Thank